Dr. Edward.
Hello. Sir, next topic is cardiogenic shock, that is pharmacological and mechanical management by Suresh Rao. Suresh Rao, sir, is a co-director of Institute of Heart Lung Transplant, MGM Healthcare, Chennai. His area of interest are heart and lung transplantation, circulatory support services, ECMO, and cardiac critical cares. His publications are more than 30 national and international journals and Vocational Excellence Award by Lions Club. He conducted several national and international conferences. Over to Suresh Rao, sir.
Very good evening all. It's a great pleasure to be here in Mysore, a beautiful city. And I thank the organizers, Dr. Dinesh, and the other organizers for giving me the opportunity. So basically I'm involved in the management of heart failure patients, heart transplantation, and institution of various mechanical circulatory supports when the heart really fails. So let us come to the cardiogenic shock. What is cardiogenic shock? Now shock can happen in various situations. If there is hypovolemia, sepsis, but if the underlying cause is primary cardiac disorder, and if there are signs of tissue hypoperfusion, it is called cardiogenic shock. There are some hemodynamic parameters, biochemical parameters like systolic blood pressure less than 90 millimeter of mercury for more than 30 minutes. Then there are signs of organ hypoperfusion, like renal hypoperfusion causes oliguria, CNS hypoperfusion causes drowsiness, restlessness. They can have cold and clammy skin because of the reduced peripheral perfusion. And if you look at the cardiac index, it is reduced to 2.2 without inotropic support. With, of course, it will be, this is with support. And pulmonary capillary wedge pressure will be more than 15. So now I will directly come to the management of cardiogenic shock. So you have various options, pharmacotherapy and various mechanical circulatory supports. The pharmacotherapy basically includes the inotropes and vasoactive drugs. Of course, you require ventilatory support and other supportive measures. And when the inotrope fails, you have mechanical circulatory supports like intra-aortic balloon pump, ECMO, tandem heart, short-term LVAD, long-duration LVAD. Then you have RVAD supports, Berlin heart, Impella. So I will explain the role of each one with the case scenarios. My talk will be mainly practical oriented and there is not much time, so I will be very brief with each topic. So coming to the inotropes. So all of you have heard about dopamine, widely used. Is it a good inotrope? No. That is because basically it causes peripheral vasoconstriction, increases the blood pressure, but actually it increases the LV afterload. So the cardiac output may actually come down. And it also causes tachyarrhythmias. And the so-called renal protective effect, it is not proved. Studies have shown that the incidence of AKI with or without dopamine, there is not much change. So then comes the dobutamine. It's a good inotrope. It increases the cardiac output. It increases the contractility. It reduces the LV afterload. However, the problem is it can cause hypotension. So in which case you may have to combine with the vasopressors. Now noradrenaline. The advantage with noradrenaline, it does increase the blood pressure. It doesn't increase the heart rate. So, but it may not be a very good inotrope, so it can be combined with the other inotropes. Then coming to the levosimendan, milrinone, they are inodilators. They increases the contractility, but they may cause vasodilatation. So they may cause a significant hypotension. So you may have to combine these things with a vasopressor like norepinephrine. Adrenaline, it's a very good inotrope, but the problem is it can cause arrhythmias. And also, studies have shown that the lactate levels increase when it is used in cardiogenic shock. Of course, if you don't have an option, you may have to go ahead with the adrenaline. And isoprenaline, again, it has got beta 1 and beta 2 action. It increases the heart rate, increases the cardiac output, but it's not advisable to use in cardiogenic shock, especially if there is acute MI, which is the underlying cause. But we use extensively in heart transplantation patients. That is because in the post-transplant period, patients may be having severe pulmonary hypertension, RV dysfunction. So isoprenaline is a good pulmonary vasodilator. It reduces the RV afterload, improves the overall RV output. Now the question is, you tried all these inotropes. Patient is not responding. Patient is in severe low output. Can you give up? No. Today we have plenty of mechanical circulatory supports. This gentleman, I will explain the role of various supports using the case scenarios. This person, 78-year-old, came to us with the acute MI, cardiogenic shock. His blood pressure was hardly 60. We started norepinephrine. Blood pressure was not increasing. Then put on IABP, no use. Then he had almost cardiac arrest. So we put him on VA ECMO, peripheral VA ECMO. With that, his condition stabilized. Now we had to treat the underlying cause. So we took him to the cath lab. It was a triple vessel disease with total occlusion of the LAD. So angioplasty was done, but his CF was poor. So we supported him for 1 week with the VA ECMO. His heart recovered, and finally we could take off the VA ECMO and send him home. So here the ECMO is used as a bridge to recovery. This is another interesting case. Now the question is, we have used IABP in acute cardiogenic shock. Now can we use that in patients who have chronic heart failure? So we had one 57-year-old gentleman having dilated cardiomyopathy, severe heart failure. He was waiting for a heart transplant. Meanwhile, he developed severe hypotension, cardiogenic shock kind of thing. So we put him on IABP. With that, his condition improved. But it was a COVID season, so the waiting period for the transplant was too long. So we wanted to wean off the IABP, but he was not tolerating. So these are some of the literature where IABP is used to support the heart in chronic heart failure. Basically, they will reduce the LV afterload, thus improves the cardiac output. So this patient was on IABP for 9 months. And meantime, we mobilized him on IABP. And finally, he had a successful heart transplantation. So here, IABP is used as a bridge to heart transplantation in patients with acute heart failure. Now, again, ECMO also used as a bridge to heart transplantation. So basically, VA ECMO, so we insert one cannula through the femoral vein into the IVC. This drains the blood from the right atrium. And it is oxygenated and pumped back into the femoral artery. So thus it maintains the systemic circulation. And sometimes there may be a distal ischemia because you have cannulated the femoral artery. So you put a distal perfusion cannula also. But VA ECMO has got some issues like North-South syndrome or Harlequin syndrome, pulmonary edema. Patient may be immobilized, which may result in sarcopenia. Children, it is difficult to put them on peripheral VA ECMO. And of course, if they are on prolonged ECMO, it has got its own complications. So what is Harlequin syndrome? In peripheral ECMO, you are basically draining the IVC blood, and after oxygenating, you are giving it to the femoral artery. So the blood will flow in retrograde direction. But there will be some part of the blood which will come to the right ventricle, pumped into the pulmonary circulation. And if the patient has got pulmonary edema, there may not be gas exchange. So the deoxygenated blood will come back to the left ventricle, which pumps to the aorta. So the heart and the central nervous system gets the deoxygenated blood. We call it north-south syndrome. So how will you manage this? Either you convert peripheral VA ECMO into a central ECMO, or you can convert this into VA-V ECMO. That means part of the blood you are giving it back to the femoral artery, and part of the oxygenated blood you will give it to the SVC by putting a separate cannula into the SVC. So thus oxygenated blood will come to the RV, goes to the lung. It doesn't matter whether the lung is working or not, it will come to the LV and pumped into the aorta. Pulmonary edema again is an issue. Because you are giving the blood in the retrograde fashion, there will be increased LV afterload, LV get distended, LA pressure goes up, they can have pulmonary edema. So how will you manage? Sometimes we do what is called atrial septostomy. So this will prevent LA pressure going up. Or again, you can convert this to central ECMO. Or you can use tandem heart. Tandem heart, basically you insert a cannula from the femoral vein into the RA and through a septostomy into the LA. So it drains the LA blood and gives it back to the femoral artery. So there is no distension of the left ventricle. Again, when the patient is put on ECMO, we don't keep them paralyzed or sedated. We'll try to mobilize them because maintaining the muscle mass is very important if you want to have a good result with ECMO. And coming to the children, I said peripheral VA ECMO is difficult. So this particular child had restrictive heart disease, severe heart failure. So we put him on central ECMO. So central ECMO basically requires sternotomy. And finally he got a heart and he underwent a successful heart transplantation. So here ECMO is used as a bridge to heart transplantation. This is another interesting case. We had a 26-year young Nigerian, dilated cardiomyopathy. He was on inotropes. He was deteriorating, put on IABP, no use. Then he had a circulatory collapse. So finally we put him on peripheral VA ECMO. Now, usually international patient won't get organs easily. Only if there are no Indians, organ will be allotted to them. So what we did was, we converted VA ECMO into LVAD. LVAD doesn't require oxygenator and it can be used for a longer duration. So this is the patient. You can see the IABP, peripheral VA ECMO, and he was brought to the theater for putting the LVAD. If you look at the ventricle, it's hardly moving. Patient is surviving only because of the VA ECMO. It is providing the circulatory support. So we instituted the LVAD. This patient is on LVAD. So there are two cannulas coming. One is draining the left ventricle and the blood is given back to the aorta. So basically this is acting as a pump replacing the left ventricle. So he was on LVAD for a few months. Then finally, this is the echo. So the heart is hardly functioning. So he was surviving mainly because of the LVAD. Luckily, he got a heart in few months' time. He underwent a successful heart transplant. And of course, he did well. This is another interesting case. This gentleman had acute MI. However, it was a delayed presentation because he went to a gastroenterologist. Then he was treated with some antacids thinking that it is acute gastritis. He came to us, collapsed. We put him on VA ECMO. Then we wanted to give some try. So we put him on BiVAD. See, there are two pumps. One is for the right ventricle, one is for the left ventricle. So he was on BiVAD for some time. Heart did not improve. And finally, we did the heart transplantation. This is during the post-heart transplantation period. Now, what about the children? Managing children is a challenge. We don't have many pumps. We can use centrifugal pumps for short duration. You can use Berlin heart for a longer duration. So this child, again, severe dilated cardiomyopathy, developed hypotension, intubated, put on ventilator, severe heart failure. So we put him on LVAD. So you can actually see the two cannula coming out, and the pump, Centrimag pump is used. He was on LVAD support for 1 month before getting a successful heart transplantation. Again, you can't continue these pumps for longer period, so we use Berlin heart. This is the Berlin heart. Basically, this child had biventricular failure, so we use 2 Berlin heart. Now, the 1 Berlin heart drains the right atrium and gives the blood back to the pulmonary artery, so which is assisting the right ventricle. The other one draining the blood from the LA and gives the blood back to the aorta. So both the ventricles are supported with Berlin heart. So this is in the post-operative period. You can see the 2 pumps outside the body. Basically, these pumps are supporting the heart. And this can be used for longer duration, as long as 2 years. This child was on BIVAD, this Berlin heart, for 1.5 years. However, they need to be in the hospital. So we need to monitor the pump, emptying of the pump. So it gives a pulsatile flow also. And finally, he had the successful transplant, and he did well. Now coming to the long duration LVAD, sometimes patients may not recover, heart may not recover, heart may not be available for transplant. So then you can use implantable LVADs. This is the HeartMate 3 and HeartMate 2, HeartMate 3. Basically, they drain blood from the LV, gives it back to the aorta. And this particular gentleman is on LVAD. However, he developed right ventricular failure. So he put a temporary RVAD. This is the temporary RVAD. Then finally, we could wean off the temporary RVAD. Now he is only on LVAD. So this is the battery he is carrying for that pump. So he went home with permanent LVAD. His heart is hardly pumping. This is another case where we are implanting the HeartMate 3. It's a implantable LVAD. And this is in the post-implantation period. Basically, he came with severe heart failure. And he was not a candidate for heart transplant also. So we implanted the LVAD, and he's doing his daily routine. This is another interesting case. If you look at the echo, the heart is not pumping at all. And if you look at the ECG, there is ventricular fibrillation, but he is talking. How? He is on LVAD. We implanted LVAD 1 year back. He came for a follow-up. Of course, he had VF, but we gave antiarrhythmics and could get back the rhythm. How about the right ventricle? If you need temporary right ventricular support, you can use Protect Duo cannula. So basically, this has 2 lumens. One lumen drains the right atrial blood, and the blood is pumped back into the pulmonary artery using an external pump. So this can support the right ventricle. It decompresses the right ventricle. Once the RV recovers, you can take out this RVAD support. Now Impella is the new one, widely used, especially in acute cardiogenic shock. So the Impella is basically introduced through the femoral artery or subclavian artery into the LV. It will have 2 ports. One port sucks the blood from the left ventricle, and the other port delivers the blood into the aorta. So basically it works as a left ventricle. Now, sometimes, as I said earlier, there is something called ECMO with Impella. I will tell one interesting story. Once we got a call from a neighboring hospital saying that one young lady is having repeated cardiac arrest. So our team went there, and we couldn't get her back, so we put her on ECMO, VA ECMO, shifted to our hospital. Then we did the angiogram. The coronaries were normal. Basically, it was a case of acute myocarditis, viral myocarditis. So if you look at the echo, there was LV was severely distended. So we put a Impella also. So here you can see the Impella console. This is the Impella. And of course the ECMO. So eventually right ventricle improved, because ECMO supports the right ventricle. Once the right ventricle improved, we removed the ECMO. She was on Impella for another 1 week. the left ventricle recovered. Then finally we could take off the impella also, and she went home. So to conclude, pharmacotherapy with inotropes and vasoactive agents are the first line of therapy in acute cardiogenic shock. If you cannot resuscitate with inotropes, then you can go for various mechanical circulatory supports like IABP, veno arterial ECMO, impella, tandem heart, LVAD, RVAD, BiVAD as a bridge to recovery. If the heart doesn't recover, of course, you can have heart transplantation done, or you can go for destination LVAD, where you implant the LVAD inside the chest cavity and you can discharge them home. Thank you very much.
Thank you, sir.